Hi, I'm Dr. Anita Saxena. I'm additional professor in the Department of Nephrology, SGPGI, Lucknow. Today I'm going to talk to you about nutritional support in patients with acute kidney injury. Now, acute kidney injury is a broad clinical syndrome encompassing various etiologies. It's a common complication affecting approximately 5% of hospitalized patients and 10 to 30% of patients managed in intensive care units. It is characterized by sudden decline of GFR, accumulation of metabolic waste products, toxins and drugs, and derangement in protein, lipid, and carbohydrate metabolism, insulin resistance, and body composition. It is best described as a triad of nutritional changes. That is, it has hyperglycemia, hypercatabolism, and hypertriglyceridemia. Now, this is the criteria for staging of acute kidney injury according to severity, and the criteria for it is increase in serum creatinine and decline in urine output. So it has three stages: 1, 2, and 3. Stage 1 is when the urine output is less than 0.5 ml per kg per hour for 6 to 12 hours. Stage 2 is when urine output is less than 0.5 ml per kg per hour for more than 12 hours. And stage 3 is when urine output is less than 0.3 ml per kg per hour for 12 to 24 hours, or if there is anuria for more than 12 hours. Now, there's high prevalence of malnutrition in AKI, and it is associated with morbidity and mortality. Studies have shown that in mildly malnourished AKI patients, the mortality is up to 20%. In moderately malnourished patients, the mortality is up to 60%. And in hypercatabolic patients, the mortality can be up to 80%. Now, the causes of AKI are varied, like sepsis, critical illness, circulatory shock, burns, nephrotoxic drugs, radiocontrast agents, poisonous plants and animals, dehydration or volume depletion, chronic diseases like heart, lung, liver, diabetes mellitus, cancer, and anemia. Now, AKI can be prerenal, intrarenal, or postrenal. And we know that AKI is a hypercatabolic state, and the causes of hypercatabolism which lead to protein energy wasting are insulin resistance, inflammatory mediators, acidosis, catabolic hormones, activation of muscle protein catabolism, gluconeogenesis, inadequate delivery of nutritional substrates, changes in amino acid metabolism. All of these things lead to loss of lean body mass. In short, protein energy wasting is caused by poor nutrient intake and high catabolic rate, which leads to negative calorie intake and nitrogen balance, and it leads to accumulation of uremic toxins and inflammation. And therefore, negative nitrogen balance is associated with worse outcomes in patients receiving mixed nutritional support. Now, AKI causes activation of protein catabolism. Now, even though the full calories are provided to patients in acute stage of critical illness, the cytokine and hormonal milieu result in unavoidable protein catabolism. So even giving calorie to your patient or energy to your patient is not going to prevent protein catabolism because of the activation of cytokines. So this AKI causes plasma intracellular components of amino acid pools to be altered. The amino acid oxidation is stimulated. Tissue utilization of exogenously infused amino acid is impaired. Amino acid transport into muscle is reduced. There is elevated level of phenylalanine, methionine, taurine, and cysteine. And on the other hand, there is decreased level of serum valine, leucine, glutamine. And what happens is the non-essential amino acids become conditionally essential. Now, kidneys are responsible for 15 to 25% of gluconeogenesis, 10 to 20% of glucose uptake, and 30% of insulin catabolism. And AKI is associated with hyperglycemia because of insulin resistance and loss of kidney function. Gluconeogenesis cannot be suppressed by even exogenous glucose infusion. The rate of endogenous insulin secretion is low. The insulin degradation is decreased in kidney, and hepatic catabolism of insulin is also decreased. Now, the purpose of nutritional support in AKI is to achieve normal glycemia and prevent hypoglycemia. So the average blood sugar should not exceed 150 milligrams per deciliter, and if required, use insulin therapy. And blood glucose should not be less than 110 milligrams per deciliter in order to prevent hypoglycemia. Studies have shown that tight glycemic control should be considered in order to reduce morbidity, mortality, and the stay in the hospital in AKI patients. Now, lipid metabolism is also deranged. The lipolysis is impaired, which leads to plasma lipid changes. Activity of both peripheral lipoprotein lipase and hepatic triglyceride lipase is reduced by 50%. Therefore, the plasma levels of triglycerides and VLDL are increased. Plasma levels of HDL and LDL are decreased. There's reduced fat clearance following parenteral administration of lipids. Now, since fatty acid oxidation is preserved, lipids can be used as energy substrate in AKI. Now, the traditional nutritional markers are not reliable due to hypercatabolic state in AKI. Therefore, the Nutrix score, which is nutritional screening tool for ICU patients, has been developed in order to identify adverse events to modify nutritional therapy. Now, this tool consists of or includes age as a factor, Apache 2 score, the SOFA score, the number of comorbidities, and the days from hospital to ICU admission, and the IL-6 levels. Therefore, it is recommended that all ICU admissions should be screened to assess need for nutrition support, and nutritional support should be initiated within 24 to 48 hours of ICU admission once the patient is hemodynamically stable. Now, nutritional strategies aim at avoiding development of deficiency states and of hospital-acquired malnutrition, like you can see in this case, and progression from oliguric to anuric state. The key aspect of the treatment of acute kidney injury is fluid balance to restore cardiac output, blood pressure, GFR, increase urine output, dilute tubular toxins, and attenuate tubular obstructions from cast. Now let's first talk about volume overload. One has to initiate renal replacement therapy when life-threatening changes in fluid, electrolyte, and acid-base balance exist. Quantify extracellular and intercellular volume expansion using bioelectrical impedance technique. This is the bioelectrical impedance tool, which is very handy. It is not very expensive either, and it's a bedside tool. Correct interstitial edema by correcting plasma colloid osmotic pressure in order to prevent hypotension during hemodialysis. Now, CRRT allows time for vascular refilling and effective control of fluid balance while maintaining hemodynamic stability of the patient. Now, for initial expansion of intravascular volume, use isotonic crystalloids rather than colloids in the absence of hemorrhagic shock. The SAFE study, Christmas study, and the CHEST study have all shown that if additional fluid is required, only then colloids should be used to prevent volume overload. Now, frequent administration of 0.9% saline in the ICU for drugs can cause hyperchloremia, which is associated with reduced renal blood flow and impaired sodium excretion, causing edema. Now, oliguria is related to reduced GFR and increased salt and water retention. Therefore, one has to restrict sodium and water, as fluid overload can cause intra-abdominal hypertension, cerebral, pulmonary, and gut edema, which eventually is going to affect nutritional intake and absorption of drugs, hepatic congestion, and worsen AKI. So, restrict fluid. If patient is in the volume overload and has low urine output, fluid intake should include 24-hour urine output and 500 ml or less if edema is present. Monitor changes in body weight and fluid intake daily. Use actual weight prior to illness as target dry weight. Restrict fluid intake according to 24-hour urine output, edema, IV fluid infusions. You must take into consideration how much IV infusions you're giving, and you have to subtract that much in from the whatever you're going to prescribe as fluid intake. And oral fluid for the last 24 hours should include a complete quantity of water, milk, tea, and curd, or any other liquid the patient has taken. Now, weight status, we know, is frequently altered by changes in volume status and dialysis in these patients. So use edema-free current weight as dosing weight, because if you calculate calorie intake based on ideal body weight, that can lead to administration of excess calories and induce refeeding syndrome. We'll be talking about this later on. Now, aggressive use of loop diuretics for removal of fluid can cause electrolyte imbalance and induce hypokalemia, hypernatremia, worsen renal function, lead to altered sensorium, and eventually compromise nutritional intake of the patient. Now, hypokalemia and hypomagnesemia together play a role in pathogenesis of gastroparesis, and we see our patients do have it. Is not necessarily the patient has to be diabetic in order to have the gastroparesis. Even a non-diabetic patient can have gastroparesis. So therefore, replace electrolytes as and when required. Hypokalemia To treat hypokalemia, potassium replacement is 1 milliequal per kg body weight per day. Oral KCl contains like 1 teaspoon of oral KCl contains 6 milliequals of potassium, and IV KCl should be given about 60 to 80 milliequals in 2 divided doses. Now remember that 1 gram of protein is equal to 1 milliequal of potassium. So if your patient is eating, then you must take into consideration how much protein the patient is taking. And to treat hypokalemia, you can allow your patients to take fruits and juices. Now, derangement in magnesium and phosphates can cause hypocalcemia. The patient can have convulsions, arrhythmia, tetany, and numbness, paresthesia in hands, feet, around mouth and lips. So, correct deficit with 10% calcium gluconate over 10 minutes with cardiac monitoring. And if you have to give oral calcium supplement, then do not give them with meals, otherwise they will act as phosphate binders. Now, hyponatremia can be either nutritional or dilutional or both. If the patient has not been eating for a long period of time, then he can have nutritional hyponatremia. But if the patient is into volume overload, he'll have dilutional hyponatremia. So for dilutional hyponatremia, you will use diuretic therapy. Now, the amount of sodium that you have to count is that 1 teaspoon of salt is 5 grams and contains 2.5 grams of sodium. So you can use salt plain or salt capsules to correct hyponatremia in these patients. Now, intensive RRT can readily correct electrolyte abnormalities by appropriate regulation of the composition of hemodialysis, hemofiltration fluids, and the intensity of RRT. High efficient modalities of renal replacement therapy often remove phosphates and magnesium and induce hypophosphatemia and hypomagnesemia. Therefore, these deficiencies must be corrected. Now, correct hyperkalemia, which is of non-dietary cause. Severe cases of hyperkalemia require hemodialysis. But if dialysis is not indicated, then use antihyperkalemic measures like IV calcium gluconate along with dextrose and insulin. Bicarbonate therapy can help in shifting potassium into the cells. Resins along with laxatives can be given for defecation. Diuretics like furosemide and torsemide promote excretion of potassium. So you can use all these measures. But also along with this, restrict fruits and fruit juices, remove offending medications, check inadequacy of dialysis, and use potassium-free dialysate for dialysis, and also control consumption of nutritional supplements which are not renal specific. Treat decreased gut excretion, which may cause chronic constipation. Therefore, increase fiber in diet to promote gut motility if your patient is eating well, and change phosphate binding agents to reduce constipative effects. Now, metabolic acidosis increases breakdown of muscle protein. In order to prevent protein catabolism, correct metabolic acidosis, serum bicarbonate levels must be maintained at more than 22 mmol per liter, and you can supplement sodium bicarbonate 0.9 to 1 gram per kg body weight per day to the patients. Now, hypercatabolism is the main nutritional change in AKI. So the patients who have AKI can be classified based on the amount of catabolism they are having. Like they can be mildly catabolic, moderately catabolic, or severely catabolic. AKI stage 1 patients are called mild catabolic patients because their losses of nitrogen are less than 6 grams above nitrogen intake, and AKI stages 2 and 3 are called the moderately catabolic because the losses of nitrogen are between 6 to 12 grams, and severely catabolic patients are AKI stage 3 where the losses of nitrogen are more than 12 grams per day. And these patients require very frequently dialysis, while patients in AKI stage 1 may not require dialysis, but other stages 2 and 3 would require dialysis. Now, this table is showing you the nutrient requirement according to catabolism. Here you can see this is the extent of catabolism. So a mildly catabolic patient or a moderately catabolic patient or a severely catabolic patient. Now, what nutrients do they require and in how much quantity? So a patient who is mildly catabolic requires 0.8 grams per kg body weight per day of protein. He may not require dialysis. He can take oral feeds, but you have to give them minerals and vitamins. They can take regular food, and that too with protein of high biological value like chapati, rice, bread, dosa, idli, dal, egg, curd, milk, and cheese. The energy recommendation for any patient with AKI is that it should not exceed 30 kilocalories per kg body weight per day in order to prevent refeeding syndrome. So for a patient who is mildly catabolic, you can always give him 25 to 30 kilocalories per kg body weight per day. The energy substrate will have to be glucose, and the carbohydrate should not exceed 5 grams should not exceed 7 grams per kg body weight per day. Ideal is to give carbohydrate between 3 to 5 grams per kg body weight per day. Fat should be between 0.6 to 1 gram per kg body weight per day. These patients may require essential amino acids and non-essential amino acids. And vitamin supplementation is a must for all these patients. So you must give them folic acid, thiamine, pyridoxine, vitamin C, that is 60 milligrams, to patients who are not on dialysis. Zinc supplementation and selenium supplementation is important for these patients. Now, coming to moderately catabolic patients, you have to prescribe them a protein which is 1 to 1.5 grams per kg body weight per day. And for patients who are severely catabolic, you prescribe them up to 1.7 grams 1.7 grams per kg body weight per day of protein, but do not exceed 1.7 grams at all. Otherwise, and the patients will have problems. And these patients do require dialysis and hemofiltration, and they do require enteral feeding and parenteral feeding. The enteral formula should comprise glucose 50 to 70%, fat emulsions 10 to 20%, and the calorie is again 25 to 30%. And for these patients, the energy substrate is not glucose, but it is glucose and fat. So the RRT, they require 150 to 200 milligrams of vitamin C because vitamin C is lost. Now, energy expenditure can be influenced by RRT. So non-protein calories should be at least 25 kilocalories per kg body weight per day. And in the recovery phase or the polyuric phase, maintain intravascular volume as diuresis can exceed 150 to 200 ml per hour, and the kidneys, which are regaining function, are unable to produce a concentrated urine, risking volume depletion and a recurrent AKI. So you must be careful that the patient should not go into recurrent AKI, which will be hospital-based. And now, protein requirement for such patients will be 0.97 to 1.3 grams per kg body weight per day. Renal-specific oral nutritional supplements can be given to these patients because they may not like the regular food, but both oral and IV amino acids increase renal blood flow and GFR. And in patients with AKI, 1.5 grams per kg body weight per day of protein increases creatinine clearance and reduces requirement for diuretics. This is a patient who is mildly catabolic, and so he's taking oral feeds, and we are giving him supplements of water-soluble vitamins and zinc. Here you see these are the foods which contain protein of high biological value, the milk and milk products, soya and soya products, then fish, egg, and chicken. And here is a diet plan for catabolic patients and patients who are in the recovery phase. So you can give these patients cow's milk, curd, sambar or dal, fish, chicken or chana, dosa, utpam, chapati, bread slice porridge, rice, egg white, paneer. And this thing will bring them about 64 grams of protein and 1600 kilocalories. But if you have to give some more energy and some more protein to your patients, you can add protein-specific protein supplements, renal-specific protein supplements, so 60 to 70%. That will bring the protein intake to more than 70 grams per 70 grams per day, and calories more than 1700 grams kilocalories per kg body weight per day. Now, a lot of studies have shown, particularly the renal study has shown that patients with AKI have a low dietary calorie intake, which is actually 11 kilocalories per kg body weight per day, which makes the patient become more malnourished. The ESPN guidelines on enteral nutrition have recommended that in cases where normal food intake is inadequate, enteral nutrition by means of oral nutritional supplements and tube feeding offers the possibility of increasing or ensuring nutrient intake. Therefore, starting enteral nutrition within 3 days of intensive care unit admission reduces duration of mechanical ventilation and improves nutrition. Now, gut hypothesis of multiple organ failure recommends that enteral nutrition be started as soon as possible after surgery or in non-surgical patients after admission to the intensive care unit. Enteral nutrition preserves planktonic flow and prevents mucosal breakdown, lowers stress hormone concentrations, lowers infection rates, shortens hospital stay, and patients have better survival. Now, this is a decision tree for nutritional support in acute kidney injury patients with protein energy wasting or patients who are at risk of developing protein energy wasting. And the deciding factor is whether the GI tract is functioning or not. Now, if GI tract is functioning, you can switch over to enteral nutrition or enteral feeding, and if the nutritional goals are achieved, continue with it. However, if the nutritional goals are not achieved, then integrate it with parenteral feeding. And parenteral feeding would be whether you want it's a short term with or without fluid restriction. It can be through peripheral route, or if it is a long term fluid restriction with hypercatabolism, then it has to be a central route. Now, if GI tract is not functioning, then definitely you have to resort to the parenteral feeding. Now, provide nutrition preferentially via enteral route. Patients with renal injury, we know, frequently require volume restriction. If oral feeding is not possible, then enteral feeding, that is tube feeding, must be initiated within 24 hours of admission or maximum 48 hours. And patients with delayed gastric emptying may require use of calorie-dense formula and slower feeding rate. Now you must avoid giving hyperosmolar enteral nutrition as it predisposes patients to diarrhea or symptoms similar to dumping syndrome if it is infused rapidly. Now, what is dumping syndrome? Dumping syndrome is characterized by symptoms of nausea, shaking, diaphoresis, and diarrhea shortly after eating foods containing high amounts of refined sugar. The amount of enteral nutrition that should be tailored to the nutritional and fluid needs of the patient. Use renal specific formulae with high energy, that is 2 kilocal per ml, and high protein content and low electrolyte levels. Overnight supplement can lead to a sufficient improvement in nutritional status and overall well-being. If you want, you can start your patient on bolus feeding. Start with 50 to 100 ml, then increase it to 300 to 400 ml per feeding. Or if you want to put your patient on continuous feeding, start with 20 to 50 ml per hour, increase 20 ml every 2 hours. Actually, you can, depending upon the condition of the patient, you can increase 20 ml every 2 to 8 hours until requirement is achieved. Now, patient can be given churn diet, which will give them full nutrition that a person usually is used to. Then you must monitor enteral nutrition. Check patient's gastric residual volume prior to increasing the infusion rate. Discontinue infusion if gastric residual volume exceeds 150 to 250 ml to minimize the risk of unrecognized gastric fluid accumulation and vomiting. Use motility agents which may help achieve desired rate of feeding in patients with poor gastric emptying. If enteral feeding cannot be initiated within 24 hours of ICU admission because of impaired gastrointestinal motility and decreased absorption of nutrients secondary to bowel edema, or if enteral nutrition appears inadequate, then parenteral nutrition should be started. Consider intradialytic parenteral nutrition in case the patient is on hemodialysis, and intraperitoneal 1.1% amino acids if the patient is on peritoneal dialysis. I use glucose as the main energy substrate. However, glucose intake must be restricted to 3 to 5 grams per kg body weight per day, as I've already mentioned. Neutralize with insulin if required. Use parenteral solutions containing both essential and non-essential amino acids in standard proportions or in special proportions if you have access to them. Monitor side effects of parenteral nutrition like vomiting and infusion site tenderness. Now, fatty acid oxidation is preserved in AKI, therefore lipids can be used as energy substrate, which also reduces risk of developing hyperglycemia. Lipids should represent 30 to 35% of total non-protein energy, and 1 gram fat per kg body weight per day can be infused over 10 to 18 hours. But you must monitor serum triglycerides during this period. Stop lipid administration if triglycerides exceed 400 milligrams per deciliter, and prefer administering lipids during hemodialysis or hemofiltration, as lipids are not lost through filters. Now, this is a schedule for minimal monitoring of parenteral nutrition. Here, the frequency of testing depends on the metabolic stability of the patient. You must repeatedly monitor plasma glucose levels, potassium, phosphates after starting parenteral nutrition. This is a must. But the disadvantage of parenteral nutrition is it requires a greater fluid volume to meet calorie and protein needs. It is associated with increased infectious complications and is significantly more expensive than enteral feeding. Now, a word about AKI patients on CRRT. These patients are at risk of developing micronutrient deficiencies. Therefore, supplement water-soluble vitamins, especially folic acid, thiamine, pyridoxine, vitamin C. During CRRT, a lot of vitamin C is lost, so you can jack up vitamin C to say 200 milligrams in these patients. Iron supplements should be given to those patients who are receiving erythropoietin, provided they have iron deficiency. Zinc and selenium should be supplemented along with, and copper as well should be supplemented, because patients tend to go into negative balance, especially those who are on CRRT. Now, activation of vitamin D3 is impaired in AKI patients. So, therefore, if a patient has 25 hydroxyvitamin D less than 75, they should receive standard vitamin D supplement. But, however, I must tell you that there are no standard recommendations for trace elements in AKI, but supplementation should be done as per the requirement. Now, in AKI, about 125 grams per day of tissue protein is lost and is rapidly degraded, leading to deterioration in cellular function. So, patients on PD have a higher loss of protein, which is up to 48 grams per day, which can lead to extensive malnutrition in these patients. So, you must ensure a high protein intake for these patients, be that through the parenteral nutrition or through the enteral nutrition. Now, AKI causes acute micronutrient deficiency, as I've just mentioned, fluid electrolyte imbalance, and disturbances of organ function and metabolic regulation. Therefore, feeding a malnourished patient is a real problem, because they tend to develop refeeding syndrome, which is life-threatening condition resulting from over-rapid or unbalanced nutritional support given to a malnourished patients. Now, refeeding syndrome is seen as severe hypophosphatemia, fluid balance abnormalities, hypokalemia, hypomagnesemia, altered glucose metabolism, vitamin D deficiency, cardiac failure, pulmonary edema, and dysrhythmias, neurological deficits, and risk of death. So, patients who have not eaten for more than 5 days are at risk of developing refeeding syndrome, and it usually occurs within 4 days of starting to feed. So, here is a nice criteria for determining which patients are at high risk of developing refeeding syndrome. You can see these are 2 columns. The first column is showing you if one or more of the following criteria are present, like BMI less than 16, unintentional weight loss of more than 15% within the last 3 to 6 months, little or no nutritional intake for more than 10 days, or if the patient has low levels of potassium, phosphate, or magnesium prior to feeding, this patient is definitely at a risk of developing refeeding syndrome. Now, moving to the second column, if 2 or more of the 2 are present, then the patient is at risk of developing refeeding syndrome, like BMI less than 18.5, unintentional weight loss of 10% within the last 3 to 6 months, little or no nutritional intake for more than 5 days, and a history of alcohol abuse or drug, including chemotherapy. So, for such patients who are at risk of developing refeeding syndrome, start nutrition support at less than 10 kilocalories per kg body weight per day. Surprise, but don't be, because this is the rule. Increase levels slowly to meet full requirements by day 4 to 7. So, you have to gradually step up feeding these patients. Avoid overfeeding patients with raised or increasing inotropic requirements. So, I conclude my talk by saying that nutritional support should be initiated within 24 to 48 hours to correct deficits. Combine enteral and parenteral nutrition. High efficient modalities of RRT often remove phosphates and magnesium and induce hypophosphatemia and hypomagnesemia. So, you must correct these deficiencies. Control blood sugar, as normal glycemia is renoprotective and reduces AKI incidence. There are several randomized controlled trials which suggest that intensive insulin therapy is beneficial, but this topic is very controversial. Support immune function with glutamine, leucine, or its keto acids to exert anti-catabolic response. Glutamine powder can be mixed with water. 2 to 3 doses can be given. That is 0.3 or 2.5 grams glutamine per kg body weight per day. Minimize inflammation with glycine, arginine, and inflammatory mediators like omega-3 fatty acids or antioxidants. Thank you for your attention.